Good morning, everybody. Today we're going to be talking about the cervical chair adjustment, and we're going to take the 7 common denominators we already talked about and apply them to the cervical chair. We're going to evaluate your thrust and talk about the mechanics of the thrust first, and it's basically it's a short, quick explosion. So I want everybody to tuck their elbows in their side, make a fist, just give a short jab. Punch, 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 punch. Okay, just look around the room, all of you did a good job. That's the adjustment. It's a short, quick contraction of that tricep muscle. But you also notice, where were your elbows? Right next to your side. Okay? Once you all get Velcro shirts, put Velcro on your side, tuck your elbows into your side. Because if you've ever done any boxing or know anything about boxing, if you pull the elbows away from your body, you lose your what? You lose your power. Okay? So that comes from your center of gravity. Your center of gravity is basically around your belly button, if you will. Okay? You want to have those elbows tucked in. That's going to be true on the diversified cervical adjusting and the cervical chair adjusting. Keep the elbows tucked in. Too many people bring the elbows out the side, they don't have any power. So always think about keeping those elbows tucked into your sides. So always tuck in, or else Uncle Rick's going to come by and tickle you in the ribs. So you got to watch out for that. Okay? So keep those elbows tucked in tight. Okay? And that's all it is, short, quick punch. I saw every single one of you can do that. And I'm going to tell you, there's no such thing as a good Gonstead adjuster or a bad diversified adjuster, or vice versa. A good adjuster is a good adjuster is a good adjuster if you own those 7 common denominators. And that first one is a short, quick contraction of the tricep muscle. Okay? And you also know that we always have the segment being adjusted at our center of gravity. If you want to get really frustrated with the cervical chair, we see a lot of people trying to adjust an atlas like this. Well, if your shoulders are up around your ears, it's not going to work. Okay? So your shoulders always always relaxed, and we're always going to be adjusting from your center of gravity, so basically around your belly button. So the patient is always going to be accommodated to you. Okay? So that's the punch, if you will. Now the hands. The hands are the next thing that people worry about. We see people come in with L's and straight hands. And remember, the common denominator, all adjusting comes from relaxation of the patient and the chiropractor. So I want everybody to get a position where they let their hands just relax to their side. Bring your fingers together. Elbows at 90, tucked into your side. Now, unless you're severely deformed, okay, you have a cup in your hand, all 4 fingers are supporting each other. Okay, and that's going to be what's called the working position of the wrist. Also note that the volar surface of your wrist is going to be flat. We never have wrist wrinkles. If you want to have difficulty with all the cervicals, be it diversified or chair, okay, have a little bit of flexion, show wrist wrinkles. Because the line of drive, this is actually a national board question, the line of drive comes from the forearm is the answer. Okay? Line of drive always comes to the forearm. We just have all these neat attachments we put on the end of the forearm. In this case, it happens to be the fingers. Now, that position is a unique position. If you totally destroyed your wrist, they do what's called a 15-degree cock-up. What they do is they fuse the wrist in 15 degrees extension. Now, they're measuring on the back side of the wrist, which means the volar side of the wrist is flat. It's an interesting position because where we have maximum strength in the wrist and maximum relaxation in the hand, because we have to have that hand relaxation to get our speed, and we have to have the wrist lock to get that effect of that tricep contraction. Okay? So we're going to have the hands relaxed to the side, bring the fingers together, then we're going to have the punch, 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 punch. The next step, from C2 down to T2, and we teach it the cervical chair down to T2, your hands may not go to T2. Some of you may have hands big enough for T3. But the ranges we teach are occiput down to T2. But C2 down to T2, we always have torque. The torque in the cervical chair is not for the wedge. It is not for the wedge, it's for the I to S lift. It's for the I to S lift. If you'll think about it, we always are going to be supinating. So you don't have to look at the clock anymore and think, well, what am I going to be doing? Is it clockwise count? It's always supination. So, hands relax to your side. Okay, elbows tucked inside. I don't want you to worry about the punch this time. I just want you to worry about supination. Supinate, supinate, supinate. Now, that's going to be your I to S lift, because you have to lift it before you set it, lift it before you set it, lift before you set it, lift before you set it, lift before you set it. Okay, just worry about the supination. It's always supination, so you don't have to worry about the clock anymore. It's going to be the same thing for the atlas. Okay, AS atlases. We're always supinated. So you don't have to worry about any muscle action besides supination. Now put it all together. Hands relaxed to the side. Elbows tucked in. Now we're going to supinate punch, supinate punch, supinate punch, supinate punch, supinate punch, supinate punch. Let me see you. Aw, come on. Let's look around the room. Majority of you have enough thrust to move a segment. But we see a lot of you don't have that confidence in a cervical chair. You know what? Cervical chair and diversified cervical have the exact same thrust. The exact same thrust. Supine diversified, prone diversified. Elbows tucked into your side. Hands in ulnar deviation. Volar surfaces locked. We have the fingers pointing toward the floor, and we bend over a little bit. Tricep pec bod for supine or prone diversified cervical. Cervical chair is the exact same thing, except palms toward the ceiling. That's the only difference. Tricep pec bod. Body weight shifting forward and balls your feet. Okay? So if you can do one, you can do all. So where's the difference lie? Most of it right between your ears. Okay? If you think you can, you can. Okay? But there is one very important difference, is a cervical chair is 100% dependent upon fixation. Where diversified cervicals or traction leverage moves, I can lateral bend and rotate, bring any segment to a point of tension, be it fixed or not. So that's why it's easier to learn diversified, because we can lateral bend and rotate and get a feel for a segment. Because it doesn't matter, they're not dependent upon fixation. Where cervical chair, you're 100% depending on having fixation. If you think about it, you're always on the fixed side. You're always on the fixed side. PSRS, ASR, PR, PRS, PLI, HL, PLI, HL. You're always on the fixed side. So you have to have that fixation. So when we say everybody set up on a C6 PRS, it's hard to feel it because the odds of you being on a C6 PRS are slim to none. So when you're practicing on your own from now on, make sure you at least go through the process of finding a fixation and set up on that fixation. And the feel for the setup will go to that next level. So it's very important you have that fixation. So the parts of the adjustment, we're going to have tricep contraction, we're going to have the supination, and we're going to have the pectoralis punch. We're also going to have our body weight shifting forward in the balls of our feet. So we're going to be talking about what's called a contact leg. Okay? If I'm doing a right hand contact, I have my right foot back, and I'm pushing off that right foot. So I'm pushing off that right foot to get my body mass in behind, depth of the pectoralis muscle, and speed of the tricep. Okay? And that elbow's always tucked in the side, and you're going to find the knee is always below the elbow. So if I'm doing a C6 PR, my right leg slightly behind the left, my elbow's tucked in the side, the elbow's below it, and I'm pushing off in that direction. Okay? PLI to HL, I step around more behind the patient. Elbow, knee, the same position. PSRS, we step out approximately 45-degree angle, pushing off that foot. ASR, foot comes up the side, but again, that knee is always going to be right underneath my elbow because I'm going to have pushing off that contact leg. So you're going to see no matter where you go, you're always going to have that knee and foot lined up in the direction of line of drive. If you can relate it to golf, those of you who know how to golf, you know when you're taking your golf swing, you always have your target line. The target line is across the tips of your toes. If you've ever done a golf exercise or you laid a club across your toes, that's your target. Same thing with the chair. We'll always be putting our feet in the direction of our target. So your feet are lined up with your line of drive, which gets your body mass in behind, depth, and speed. So any question on the thrust? Any question on the thrust? Now, the stabilization is really important. Your stabilization hand is totally relaxed, and then all of a sudden it's going to be set and catch, set and catch, set and catch. We see a lot of people get in the bad habit of pulling back with the stabilization hand, and if you do that, what you do is get a progressive rattle on the stabilization hand side. You should always feel the release with the adjustment with what hand? Contact or stabilization hand? Contact hand. If you feel the stabilization hand, it meant you had a poor what? Stabilization. So it's not a matter of just making noise. It's real easy to make noise, just have a bad stabilization. You can always make a lot of noise with bad stabilization, but it's usually on the contralateral side. Okay? We always want to make sure we get the release with the contact hand side. So your hand's totally still and set into it. If you've ever played catch with yourself, it's the exact same thing with your glove hand. Your glove hand was totally relaxed, but as soon as that ball hits your glove, you tighten up. You didn't have that hand just rock hard and, oh, I hope I'm going to catch the ball. Your glove hand was totally relaxed, but as soon as that ball hits that glove, you instinctively contract to catch it. The adjustive thrust is the exact same thing. We're going to call it set and catch, set and catch, set and catch, set and catch. So you're not ripping back towards you, and we have some of you actually push down. Okay, just hold the thing still, set and catch, set and catch. That's going to be true for lower cervicals, okay, occiput, atlas. Okay, you're always going to be catching that segment you're thrusting them on. Okay, so you're totally relaxed, boom. Okay, any question on the mechanics of the thrust? Okay, Brandon, if I can borrow you, please. Now I've already motion palpated Brent and found he had a fixation on the left lateral bending. So which hand do you think I'm going to demonstrate with? The left hand. Because I would have to hold him in position to do the entire lecture. Now I'm going to be demonstrating both left and right hand as we go, but I'm going to have to play act just a little bit with the right hand side. Everybody follow? So we're going to go through this like dance steps. Everything you do, you have to get the choreography. It's just like when you learn to drive. You learn to drive by the steps. Okay? You have to learn to adjust by the steps. You'll start off 1, 2, 3, 4, 5, but eventually go 1, 5. Everybody follow? Okay. So it's very important you learn by the steps. If you learn by the steps, then those steps become a subconscious thing, and then eventually it just happens. You don't have to think about it. So, first thing we're going to do is place the patient. I'm always going to place the patient near my center of gravity. I'm going to have my left elbow tucked into my side, and I can adjust for the line of drive as far as the disc by moving the hand up and down. Everybody follow? And you've learned the textbook that we have the arm about parallel for C5, contact slightly below elbow for 6, 7, 1, 2, then coming back up, 4, 3, 2. So you're basically following the cervical chair arc. But that is for what type of spine? A normal spine. Again, we're going to test you on normal, but when it comes to adjusting, you have to look at that patient's x-ray and know what their curve is. Everybody follow? Because, well, I have a different line of drive on Brent if he has a let's have you set straight. Let's say he's 99 years old, he's hyperkyphotic, hyperlordotic here. My line of drive for C5 is going to be probably in this direction. Everybody follow? Okay. Now, let's say you had a military neck. His cervical spine straight up and down. Now my contact is going to be slightly below my elbow. Where if he had a reverse cervical curve, now I may have my elbow down to lift up in that disc plane line. So there's no such thing as generic setup. You have to look at the x-ray of that patient and know how you're going to be x-raying or how you're going to adjust the patient. So I know what Brett's spine looks like. Up just a hair. We're just going to set up as if he was normal. Okay? So we're going to be setting up on a C5. So step 1, I place him near my center of gravity. Step 2, we place the doctor. Okay? I'm going to place my stabilization leg right underneath the block of the cervical chair. I'm going to start with simple listings. I'm going to be my left leg back and to the left slightly so that my feet are driving out the right eye, if you will. So my feet are lined up in my line of drive. Everybody have it? Next step, I'm going to tuck the chin in. I'm going to tuck your collar under here. I'm going to tuck the chin in. Then I'm going to take a strong IS skin pull if I come right up underneath that C5 spinous. Now notice I had to take a few drags to get all that IS slack out. If you were watching me adjust the other day, you notice I had to take a few tries to get that IS slack because we want all that skin pull taken out of the way. Otherwise I'm going to dissipate my thrust in that sliding of the skin. So we want all that slack taken out of the skin, but I do not want to press into what? The muscles, exactly. So if I press the muscle, he's already what? Contracted. Everybody follow? We don't want to give that patient a head start because the average muscle contracts anywhere from 0.135 to 0.247 seconds. So in order for you to give a successful adjustment, you have to be what compared to that? Faster than that. You have to be faster than that. So basically you have to come in about a tenth of a second or under to make sure you adjust it before the muscles have a chance to contract. So step 1, we place the patient. Step 2, we place the chiropractor. Step 3, we tuck the chin. Step 4, we take an itis skin pull, come right underneath the spinous. I get right underneath the corner of my finger. It's very important you understand the segmental or the contact point. You're right on the corner of that finger. Because if you're going to supinate, that's where you're going to get your maximum supination. We see a lot of people that try to bastardize this work by getting down on one of the knuckles, but then you're at the middle of your pivot. You don't get any lift. You have to get that I to S lift. That I to S lift is the real key in the cervical chair. So get right on the tip of that finger. So you should feel that spinous just laying right on that tip. So we place the patient, place the chiropractor, tuck the chin, I to S skin pull. Then, once we set our line of drive, the left side or the contact side is frozen until it's adjusting time. Everything else happens with the contact or the stabilization hand. I'm going to lateral bend the head to my hand. We never bring the hand up to the head. So we lateral bend the head to the hand. Now the fixation is what's going to hold his head. My thumb is not holding his head. My thumb is resting on his cheek, but it's not driving into his cheek. So if you feel the head heavy on your thumb, you're probably not at a fixation. Everybody follow? Now the reason we do that, if you'll think about it, we want to make the contact point a fulcrum. I'm actually bending the entire spine over that fulcrum. So I take my skin pull, come right underneath that spine. The spine is perfectly straight up to C6, and I'm going to kink it right at C5. If you bring your hand to the head and lateral bend, you get a progressive curve instead of that kink. And that's where you get that rattle on the stabilization hand side. So it's very important that once you set that contact hand, everything else happens with the stabilization hand. So we place the patient, place the chiropractor, tuck the chin, itis skin pull, come right underneath that spine, set my line of drive, we lateral bend. And I'm going to turn him and show the rest of the steps. Bear right with me with those steps so far. Great. Let's turn your face toward your friends. Okay. So again, we place the patient, step my right foot right underneath the block of the chair, leaving the left foot back into the left slightly. We tuck the chin, take an itis skin pull, set the line of drive, we lateral bend the head to the hand. That way we've isolated that one motion unit. Notice my elbow still tucked into my side. I'm not going to let it hang out like this. Tuck the elbow in the side. Then, what two motions couple together? Lateral bending and what? Rotation, exactly. Okay. So since we have rotation, you notice when we lateral bend, the nose will always go toward the side of contact. If you'll think about every move that we have in the entire curriculum, we always turn the nose to bring the segmental contact point tight into the contact point. Everybody have it? Now you've been taught to turn the nose back to midline. But that is a feel, it's not something you do by sight. There's too many people standing here looking at the patient's nose because you're off to the side looking. You'll think the patient's nose is straight here. And it's not. So it's a feel. So when you're doing these setups, I want you to close your eyes and turn the nose back to midline until you feel the segmental contact point tight to your contact point. And I promise you, you will be in midline if you do it that way. If you do it by sight, you're always going to end up with slack because you're off at an angle looking and the nose ends up turned into your contact hand. So we place the patient, place the chiropractor, tuck the chin, itis skin pull, set the line of drive. We lateral bend the head to the hand. Then the stabilization hand is going to do the rest of the work. I always start out with the fingers on the chin, my thenar in front of the ear hole. We'll call it ear hole after boards, external auditory meatus before board. Then we're going to pivot around to stabilize on C6 and below, and we're going to turn the nose back to mid. Oh, don't help me. Just a helpful guy, aren't you, bro? So we lateral bend the head, bring stabilization around, then I turn the nose till I feel that spine come tight in my finger, and we're ready to adjust. Then the adjustment, going to be tricep, pec body, tricep contraction, pectoralis punch, body weight shifting forward to balls of my feet, and I'm going to catch it with the stabilization hand. Showing your right hand, okay? Left foot underneath the block of the chair, right foot back and slightly to the right, targets the left eye. We tuck the chin, take eye to skin pull, set the line of drive, lateral bend the head over to the thumb, and I'm going to have to hold him a little bit here because he's not flexed to this side. Then I bring the stabilization hand around, turn the nose back to midline, and we're ready to adjust. Okay. Again, the adjustment, tricep, pec body. On C2, where will my elbow be in relationship to the contact point? It'll be below it. So what do you think I'll have to do with Brent for a C2? I'm going to have him sit up taller because I have to have my elbow in next to my side. Everybody have it? So C2, PL. Now this time, we're going to have him perfect with C3, but then I'm still going to kink the heck out of him at that C2. Everybody follow? So C2, PL, C2, PL. Step the right foot underneath the block of the chair, leaving the left foot back to slightly to the left. We tuck the chin. Take eye to skin pull. Lateral bend the head. So there's a lot of lateral bending at C2, but I don't want lateral bending taking place below C2. We bring the stabilization hand around to stabilize on C3 and below. Turn those back to midline. Ready to adjust. Notice the elbows below the contact. Now, it's very important that you stabilize that C3. So if you noticed, I was stabilizing with the chiropractic index finger and dragging one finger. Sometimes you can also stabilize with the ring finger and drag two fingers. But it's very important you get that C3 held. So you do two fingers or one finger, but make sure you keep the other fingers what? Off the patient's throat. Otherwise, the noise you get with the adjustment is a gasping sound. Okay? So make sure you get those fingers on the spine, not the throat. C2PL. Oh, I'm sorry, I should show this side. C2PR, step the left foot underneath the block of the chair, right foot back, tuck the chin, eye that skin pull, set line of drive, lateral bend the head, stabilize, nose back to midline, set. Any questions on simple listings? Now, the majority of your listings in the cervical spine are simple listings. Matter of fact, one of the most forgotten listings we have in the lower cervical spine is P. You will see a lot of P's where it's dropped posterior and inferior, there's no rotation, you have a military neck. So remember, there are P's out there. So P's, PRs, sometimes you will get a wedge, but there's not a lot of wedging in the cervical spine either. So most of the listings are going to be P's, PRs, PLs. Blake?
After you tuck the chin, how much do you want to extend the head back and open the joints up?
We don't want you to bring, well, first off, you open the joints up, okay, by tucking the chin in, that flares the sponges. But if you'll watch, I'll demonstrate PL again. We don't want you to physically bring the chin up, because what happens is it naturally comes up when you do what? Lateral bending. Because if you'll think about him from the side, remember what we had earlier, and you got a good angle on it, his head always ends up in what's called the loose pack position. We never have the head in extension or flexion. We always want them to end up in that loose pack position. In the loose pack position, the joint's floating, if you will. You have the segment balanced on the disc and the facets are neutral. Here's what happens We have some people do this, then they bring the chin back up. He's now an extension, I'm jamming what? Facets. If I keep it in flexion, I'm jamming what? Bodies. Where if you let his head just lateral bend naturally, he ends in that loose pack position. Everything's nice and even and makes it a lot easier to adjust. So the chin will come up naturally as you lateral bend the patient. But don't you lift it up or else you end up with that extension and you typically are jamming facets and you'll be very frustrated. Good question. Other questions? Okay. PRI-L. PRI-L. What's my target for PRI-L? Left eye or right eye? The left eye. Left eye. Now I want to always line my feet up with the target. So we place the patient, same place we just had for that C5 earlier. I place my right foot underneath the block of the chair. What will I do with my left foot? I'm going to swing it in behind the right foot, which clears my body out of the way so I can shoot out the same side eye. The biggest problem we have on dash L's is people step way out like this and try to do a supine diversified in a seated posture. Okay? The purpose of cervical chair is to correct what component primarily of the subluxation? Posteriority. So stay in behind. So actually step more behind for dash L's, not more out to the side. So PRI-L, PRI-L. Okay? We place the patient. I place my right foot underneath the block of the chair. I swing my left foot behind the right foot. That clears my body out of the way so I can shoot out the same side eye because my elbow's always going to be next to my side. My knee's always going to be right below that elbow because I have to push off my left leg this time, my contact leg. We tuck the chin in, take an IDES skin pull, and I come right up the spine, just like I did for the simple listing, and there's only one person in the room that will feel the difference. There's spinous, there's lamina. It's a lamina contact, not lam pin junction. Here's the difference. If this green pin is the spinous, I was right underneath the spinous for a simple listing. I'm beside the spinous for the rotatory listing. So your finger will always be touching what? The spinous. So your tissue pull is identical to a simple listing. You come IDES till you get that spinous, and it's a very token right to left. Because again, our goal is to correct posteriority, not rotation. Everybody have it? So we place the patient at our center of gravity. We tuck or place our stabilization leg underneath the block of the chair, leaving the contact leg straight behind the stabilization leg. We tuck the chin, come right up to spinuses, and just a token, right to left. Okay. We set the line of drive. Again, we're going to lateral bend the head to the hand. The left side's frozen. Stabilization in comes around and stabilizes in C6 and below. We turn the nose back to midline. Okay. Right there we have it. Okay. This time shooting straight ahead. Still going to have that IDES lift. Do I have it? PLI-L, PL-L, or PLI-L, either one. Stand on or place the patient to our center of gravity. I place my left foot underneath the block of the chair, swing my right foot behind the left foot, because my target's going to be the right eye. We tuck the chin, take IDES skin pull, come right underneath that spinous, and just a token, left to right. We set the line of drive, we lateral bend the head to the right. Stabilization hand comes around, stabilizing C6 and below. We turn the nose back to midline. We're ready to adjust. Okay. Any question on lower cervical, C2 to C6 if you will. Now, upper thoracics. Upper thoracics, C7, are usually very easy to learn because they're big spinuses. It's real easy to get your fingers underneath those big spinuses. It's actually more difficult to do chair on C3, 4, and 5 because they're itty bitty spinuses. Okay. Now, C7 is like a pot handle. You can just grab onto it with your whole fist practically. So the upper thoracics probably be easier ones to learn. But a lot of people get intimidated because they're bigger bones. Now think with me, for upper thoracics, T1, T2, of the component of the adjustment, do you think I'm going to need a little more tricep, a little more pec? More pec because the thoracics are a little deeper, so I need a little more what? Depth. So make sure you throw that shoulder in there when you're doing the upper thoracics. And here's the key, hitting I to S in relationship to that disc plane line. I to S in relationship to that disc plane line. These are some of the last ones I figured out because I kept getting way down like this and shooting up in this direction, which meant I was probably 90 degrees to where I should be. Learn to shoot down, shoot down, shoot down. It looks S to I, but it's I to S in relationship to that disc plane line. Should be P7. We're going to do a T2 PL. We tuck the chin in. Now notice I didn't have to change them a whole lot because now my contact's going to be below my elbow. Take I to S skin pull, come right underneath that spinous, set my line of drive. Notice I have the elbow above the contact. We lateral bend him at that T2. Now he's not fixed at T2, so I'm having to hold him just a little bit. We bring the stabilization hand around to stabilize down the side of the neck to the trapezius muscle because I can't get a hold of, obviously, T3. We turn the nose back to midline and we're ready to adjust. I'll go easy, thrusting in this direction. PR, T2. Step the left foot underneath the block of the chair. Slip off of it. Set the line of drive. Bring the head over. Stabilize. Ready to adjust, sitting down. This way. Now, for the dash T's, we're going to contact the entire transverse. So the tip of my finger will be touching the spinous, but I'm going to have the first phalanx, and sometimes maybe even part of the, the distal phalanx, not the first one. Okay. I'm going to have the distal phalanx and probably part of the middle one on the transverse. How the transverse is angled in the upper thoracics, remember? They angle up. So if this is, for instance, right transverse, I'm going to contact the finger right next to the spinous, but then I'm going to have the rest of my forefinger angling with that transverse. Everybody have it? Everything else would be exactly the same. So I take tissue pull up to the spinous, take a little bit left to right, angle the finger with the transverse, lateral bend, turn those back midline, adjust. That's a PLI-T, PRI-T. Place the right foot underneath the block of the chair, left foot straight behind. Take tissue pull up to the spinous, slight left to right, angle with the transverse, head over, turn those back to midline, and adjust. Okay, any question down to T2? Now again, your hands may not get down there, and that's okay. Because we teach the so-called average patient, average doctor, if there is such a thing. Okay. Atlas. Atlas. If I sit up on the atlas, here's a common mistake most people do. This is our ASRP. Anybody tell me what's wrong? Repeat. Turn it on. My shoulders way humped up. So, shoulders always relaxed. We take off that handy number 6 contact, put on the number 9 contact. Okay? Make sure you keep the wrist locked. And we go, and bring the arm across the belly button. Do I have it? So, I have one atlas adjustment. They're all right here, because I have to have a little bit of knee bend to keep my weight forward and balls of feet, right? So we're always going to slide the patient up or down to accommodate to the chiropractor. The chiropractor is the constant in the office, the patient's the variable. The patient's always accommodated to you, not vice versa. Because you're only going to have one atlas adjustment. So what do you think I'm going to do with Brent? I'm going to slide him down just a little bit to make this adjustment. Everybody follow? Okay. And it's going to take you a little bit of practice to figure out where that is, but you'll get it. Now, let's say he was 6'8". I may have to have him put Velcro on his tailbone to hang on for these. But I still want his cervical spine up
perpendicular to the floor because I want the cervical spine up in that loose pack position we talked about earlier. Everybody follow? We don't want to let his head fall back into extension for any of these. Everybody have it? So we always want the cervical spine perpendicular to the floor regardless of what we do with the trunk down below that. But we have to have that person at our center of gravity. So we place the patient. The next step, I'm going to demonstrate in ASR to start with. My next step is only going to place the chiropractor. I'm going to take the longitudinal arch of my contact leg. I'm going to place it straight lateral to the back leg of the chair. The how far lateral is the distance from the tip of my thumb to my elbow, which drops down to my knee. The taller you are, the further lateral you're going to be, the shorter you are, the closer to that leg of the chair. But what that does, that lines up your forearm straight across the patient's shoulder. With the atlas, the line of drive is constant, and we turn the atlas to affect rotation. If you'll think back to toggle recoil, the atlas was constant, and we changed the line of drive. Everybody follow? So we always have a line of drive straight across the shoulder. Always have a line of drive straight across the shoulder. Now, our contact point is very critical that you understand this contact point. It's not the tip of the thumb. Now, we had you down in the lower trimesters. We taught you that because you have to walk before you can run. But the contact point is actually the superior corner of that tip of the thumb. So what will the meat of my thumb be contacting? The mastoid. So the meat of the thumb will be on mastoid, and that top corner of that thumb is going to be on the atlas transverse. If you try to contact atlas transverse with the tip of the thumb, you're usually going to end up between atlas and axis. So that's why we use that superior corner. So we place the patient. Place the chiropractor by stepping my right longitudinal arch, straight lateral, to the back leg of the chair. We tuck the chin in. I'd start on the anterior aspect. I'm going to turn his head just so you can see. We start on the anterior aspect of the mastoid and slide tissue bolt S to I and A to P. So you're actually starting with the thumb open and then sliding in S to I and A to P to tuck that thumb in. So your thumb is a straight line from your radius. Again, line drive comes from what?
Forearm.
The forearm. Everybody have it? And for some reason on the atlas, that's where a lot of people get hung up on that wrist bending. So make sure you keep that wrist, that volar surface of that wrist, totally flat. Because if you let that wrist bend and you thrust, your wrist caves in. So if you end up hitting the patient in the shoulder a lot, you know your wrist is bending. So we place the patient, we place the chiropractor, tuck the chin, we take tissue pull, S to I, A to P, get right in that superior tip of that transverse, and hit the big key. Your forefingers at the back side of the neck. Your forefinger is going to palpate for a window of relaxation, and that window of relaxation is extremely small. If you don't have the patient at window of relaxation, you're probably not going to set the atlas. So I've taken the tissue pull, S to I, then you'll raise the chin up, you'll feel the muscles go tight against your forefinger. Bring the chin down, you'll feel the muscles go tight. In between those two areas, that little window of neutrality, if you will, that's where I'm going to give the adjustment. If I have his chin up a little bit, he's tight, down a little bit, he's tight. Right there. Then, once I set the line of drive, don't forget to get heavy breath. Okay. Once I set the line of drive, the right side is frozen. The contact side is frozen. I lateral bend the head to pinch my thumb. There's your lateral bending. He's stuck. We pivot around to stabilize on C2 and below, and then set. Set straight, right to left. Pushing off my right foot, if you will. Everybody have it? ASL. Take the left longitudinal arch, place it straight lateral to the back leg of the chair. That's going to place my forearm straight across the patient's shoulder. We start the thumb on the anterior superior aspect of the mastoid, slide S to I. The smaller atlas transverse on the left. We slide S to I, A to P, till we get right on that atlas transverse. Notice that the wrist is locked. We lateral bend to pinch the thumb. I can bring his chin up. Muscles go tight against my left forefinger. Down they're tight. Right there is neutral. That's what? Half inch. That's the only place I can adjust him, is that little neutral position. The pivot the stabilization hand around, stabilize, set. Now for rotation, my contact side stays the same. I turn the nose to affect rotation. And it's basically a nose width. Here would be our neutral. This would be an LA or an RP. This would be an RP or an LA. If you'll think about it, just place the atlas across the shoulder. So if it's rotated in this direction, I'm exaggerating of course, bring it across. If it's rotated in this direction, rotate to bring it across. So always just think about lining up the atlas across the shoulders. But think back to your base posterior x-rays, how much rotation do you ever see? Not a whole lot, not a whole lot. So it's just basically nose width. So ASLA, we turn the nose toward contact. There's my little window right there. ASLP, we turn the nose away from contact. ASL. Everybody have it? Notice that I did not do this and this. So you don't turn, just the patient turns. Any question on Atlas?
Can you go through the setup steps?
What's that?
Can you go through the setup steps?
We've placed the patient, placed the chiropractor, SI to P tissue pull. We lateral bend the head. We raise the lower chin to find out where that relaxation is. Pivot around to stabilize and set. Okay? Okay. Occiput. For occiput, where do you think I'm going to have to place Brent? Just a little bit lower, just a little bit lower. Because I have to set S to I and I'm wanting just below my center of gravity. I'm going to place my contact or stabilization leg underneath the block of the chair. Leave my left foot back approximately 45-degree angle. I'm going to tuck the chin in. I'm going to slide up, open thumb, back down, close the thumb. My contact's going to be the thenar. But what we actually have is that thenar is rock hard in the supramastoid groove. My thumb is on the anterior aspect of the mastoid. My second metacarpal is at the back of the mastoid. So if you'll think of it, if my right thumb is the mastoid, it's stuck. So we slide up to clear the hair out of the way, open thumb, slide back down, close thumb, and test the water. Push S to I. If you slide, you're not going to do it. Elbows tucked into my side. Lateral bend to left. That one needs it. Then we're going to pivot around, stabilize on atlas and below. And there's your occiput. P to A, S to I, left to right. Then if we want to add rotation, PSLSLA, PSLSLP. Not this and this. Showing the right side, again, we've slid the patient down just below our center of gravity. I have to have an SI line of drive. I take my left foot underneath the block of the chair, leave my right foot back approximately a 45-degree angle. We tuck the chin in, we slide up, open thumb to clear the hair out of the way, back down, close thumb, basically grab the mastoid. We lateral bend, and what step did I forget to tell you on that last one? Most important step. Lift that chin up and down to find out where that relaxation is. Muscles are tight with my right forefinger. Muscles are tight. Right there I can adjust his occiput. Anything less than that won't happen. PSRS. Stabilize atlas and below. PSRSRA. PSRSRP. In the thrust, tricep pec body. Pushing off that contact leg, then catching with the stabilization hand. Tricep contraction, pectoralis punch, body weight shifting forward, and balls of feet. Make it a good day.